toplantının bölümünde arkadaşımız İsveç'ten Bergenfelz bize paratiroid ile ilgili bir sunum yapacak. Bergenfelz çalıştığı bölümde profesör arkadaşımız, orada endokrin cerrahi bölüm başkanı, ayrıca Avrupa Endokrin Cerrahi Genel Sekreteri, minimal invazif paratiroidektomi ve servikal eksplorasyon hakkında kanıtlı dayalı yaklaşımla ilgili bize bir konferans sunacak.
Thank you, and thank you very much to the organization committee for inviting me. The topic of my talk today is bilateral cervical exploration versus minimally invasive parathyroidectomy from an evidence-based perspective. And I think this is very timely, since today there are a variety of methods available for parathyroid surgery, ranging from bilateral classical neck exploration to minimally invasive endoscopic procedures, and also operation under local anesthesia. So the question that has to be asked is actually, what are the scientific evidence to use one method versus the other? This is something that I learned from the late John Dockman, who was chief of radiology in Bethesda in the United States, and he claimed to have said the only localization procedure you need before first-time exploration for primary HPT is to localize an experienced parathyroid surgeon. And in a sense, I think this is still true today. Bilateral neck exploration is a highly successful procedure. It's one of the most successful surgical procedures that we know of. 95% of the patients are cured. The complication rate is very low, and you don't need any localization procedures. You do not need intraoperative PPH, and therefore this procedure must be said to be very cost-effective. The long-term results from operation of primary HPT are a little bit worse than the immediate, but they are still very good. This is a follow-up study from the University Hospital in Uppsala in Sweden, and after a mean of 14 years, about 8% of the patients had treatment due to hypercalcemia, and 8% had either persistent or recurrent hypercalcemia. But then the median time follow-up is 14 years, so the results are still very good. So the question must arise, why all this fuss? Well, 85 to 90% of all patients with primary HPT suffer from a solitary parathyroidadenoma, and consequently can be argued that a bilateral neck exploration is too much surgery for 85 to 90% of all these patients. The pioneer in limited parathyroid exploration was Professor Sten Tiblin, who is now deceased since a few years. He published his landmark paper in the Annals of Surgery in 1982, and it was entitled Unilateral Parathyroidectomy in Hyperparathyroidism due to Single Adenoma. This paper was controversially discussed for many, many years, and it was not widely accepted. This is actually what Professor Sten Tiblin found, and this is an original slide. Here, the zero here is the lower reference range of serum calcium level, and what he found was that after a unilateral procedure you have a not so large or so pronounced decrease of serum calcium if you compare to a variety of bilateral procedures. So Professor Sten Tiblin claimed that you have less pronounced postoperative hypercalcemia in these patients if you only explore them unilaterally. Now, since this time, surgery has moved along. Professor Sten-Tiblin used intraoperative frozen section with a oil red O staining to distinguish between a adenoma here and an normal gland here. And today we use localization procedures and intraoperative PTH. I want to present some data from the first randomized trial, which we published in the early years after the millennium, where we compared unilateral and bilateral neck exploration for primary HPT. The beauty of this study is actually that the randomization is done here before any localization procedure is done. So the patients are randomized here, and if they are randomized to the bilateral group, it is a standard bilateral neck exploration, and then follow up with calcium questionnaire medication complication after 1 to 4 days, and then after 6 weeks. In the unilateral group, we performed a preoperative sestamibi scintigraphy, and then we attempted the unilateral neck exploration with intraoperative PTH and the same follow-up scheme. The primary outcome measures from this randomized trial was postoperative medication for hypocalcemia. And there was a large effort put into this study, a lot of paperwork. And what happened? Here you have the unilateral group, here you have the bilateral group. And you can see that if the patient is explored bilaterally, they have lower serum calcium levels, more or less during all the 4 first days, but significant here on the second postoperative day. And regardless how we measure this, if we measure it as area under the curve for calcium, or the lowest calcium value reached during this period, or the number of patients with a severe hypocalcemia, or how much oral calcium the patient ingested, and that was ad libitum, or the number of patients put on vitamin D, self-reported symptoms, paresthesia, muscle cramps, etc., etc. The picture is very unanimous. The patients operated with unilateral procedure had less biochemical and symptomatic hypocalcemia. And that was partly true up to 6 weeks. After that, there is no difference. Now, today this procedure is performed most commonly with a mini incision 15 to 20 millimeters wide or long in this area, just in the middle of where the inferior thyroid artery come to the junction with the nerve and the thyroid gland. This is a picture from Professor Antonio Sitgesera. You can see here, here's the border of the sternocleidomastoid muscle. The adenoma will be here, and the incision will be here. This is a kind of a private operation. It's very difficult for the assistant to see, and it's also very difficult for the nurse, scrubbing nurse, to see. So sometimes to get people to know what we are doing in the operating room, we sometimes use this video camera on the headlight and connect it to a monitor so people around us can see what we are doing. Here's another picture, also from Professor Antonio Sitgesera, where you can see the mini incision and the adenoma is dissected out. This procedure can be done in a variety of ways. You can use the lateral approach championed by Professor Jean-François Henry in Marseille, or you can use the video-assisted approach by Professor Nicoli in Pisa. So there are a number of different options available, and the approach can be used in general or local anesthesia. However, there are a few concerns, and the concern is mainly, do we miss multiglandular disease? This was published in the Archives of Surgery by Lee and co-workers. He looked at patients published with a unilateral procedure or a bilateral procedure and found that for those patients who had a bilateral procedure, it was claimed that about 80% had a solitary adenoma, whereas from those publications where the patients had been operated unilaterally, it was more than 90% of those patients that had an adenoma, and conversely, then the hyperplasia rate was 90% in this group and 5% in that group, but the success rate was identical. So the question is, do we miss multiglandular disease that will pop up after some time and give the patient a recurrent disease? Here is another study from California that pretty much shows the same thing. Patients with a positive sestamibi scintigraphy or ultrasound, if they were unilateral explored, you found a single adenoma in 100%, but if they were bilateral explored, and that was about half of this group, only 84% had a single adenoma, and 14% had hyperplasia, but still success rate 100%. So the same question, do we miss it? Will it recur? This is one of the concerns with a limited parathyroid exploration. Another question when it comes to this is how many or how good are we in doing scientific surgery? There are until this date, only 5 single-center prospectively randomized trials where you compare selective parathyroidectomy, that is either focused or unilateral parathyroidectomy, with bilateral neck exploration. That's not too many. And in total, in these 5 trials, 326 patients were randomized. To compare, in Sweden annually, we operate 1,300 patients with primary HPT. And if you look at the numbers here in Turkey or in the United States, you can understand how few patients have been put into trials. So this is a problem. A way under this problem is to gather a lot of patients in a database prospectively for a very short time period. And this is the Scandinavian database. It's online. You can go to the homepage and take a look at it. You cannot log in because you need to be a member. This database was put into practice 2004. A quality register or a database can collect a large number of patients in a short time. There are different types of centers: university, state hospitals, smaller hospitals, subspecialties, or specialized centers and more general centers. It can identify benchmark departments and outliers, and data which we then get from this database can provide a reference for implementation and evaluation of new techniques. All data in this database is validated by an external audit of participating departments or center studies. We have a professor of endocrine surgery who visits 1 or 2 centers each year and look at all the files to see that all patients are registered in the database and that they are correctly registered. In this audit between 2004 and 2008, there were 23 departments of surgery in Sweden, Denmark, Norway, and 2,700 operations for primary HPT were registered. That number has increased now, so we are now close to 4,000 operations. The median serum level of calcium was 2.79 millimole per liter. That is, most of these patients really had a mild primary HPT. You can see that there were even some patients that had normal or high normal calcium values around 260, and only very few had more than 3.1 millimole per liter. Many localization procedures were used so in total they were used in 68% of all the patients. Sestamibi was the most popular, after that ultrasound, and then came all the other investigations. In spite of this, the surgical strategy that dominated was bilateral neck exploration, in about 2/3 of the patients. Results from operation: 82% adenoma, hyperplasia 14%, and a negative exploration 4%. As you also can see here, this is also a very nice example on that it was a mild disease. The median weight was 600 milligram, and the 25 percentile was 310 milligrams. So many of those glands are really small today, and they are therefore more difficult, I would also claim, to operate. Intraoperative PTH was used in about 30% of the patients, and it was highly accurate, but there were some false positive and false negative findings. The results of the localization procedures were in general very disappointing. You can see here a true positive localization of a solitary adenoma was found in 64% of all these sestamibi investigation, and for ultrasound it was a little bit short of 60%. This is the result of the first follow-up. You can see that at the first follow-up, short of 7% had hypercalcemia, and about 14% were treated with oral calcium and or vitamin D. We performed then a multivariate logistic regression analysis of variables associated with medically treated hypercalcemia. And to make a long story short, the use of intraoperative PTH lowered the risk for biochemical hypercalcemia with about 50%. Also, the use of localization procedure lowered the risk for hypercalcemia at this point with about 50%. Other factors of interest: number of identified glands. The more glands you identify, the larger the risk for hypercalcemia. With more weight or larger weight of the tissue, the higher risk for hypercalcemia. If an autotransplantation was performed, it was a higher risk. If the diagnosis was hyperplasia, it was a higher risk. And if it was a reoperation, it was really a high risk for postoperative hypercalcemia. But of the new techniques, it was quite clear that the use of intraoperative PTH and localization procedure decreased the risk for medically treated hypercalcemia. Here you can see the impact of localization procedure and intraoperative PTH in graphics. Here you have localization procedure, and you will appreciate the difference between the patients who had a localization procedure and those who did not have a localization procedure. And the same was true for intraoperative PTH. More to the point, if you used intraoperative PTH, you had a risk for medically treated hypercalcemia with about 10%, and if you had not, the risk was short of 17%. For localization procedure, it was almost the same, around 10%. With a localization procedure, 22% if a localization procedure was not used. And you can see, even if we analyze only primary operation, the numbers are almost identical. Within 6 weeks, 35 of these patients were reoperated, and about 10 of these patients were also cured. In total, not cured after surgery, 7% of the patients, 6% of the primary operation, and reoperation 15%. So the cure rate of the primary operation for these departments were 94%. We then again performed a multivariate logistic regression analysis of variables associated with cure, and you see again the use of intraoperative PTH made cure more likely than if it was not used. Other factors then were also found to be significant: the number of excised parathyroid glands, the number of identified parathyroid glands, and also in primary operation, you had it was more likely to cure the patient. Here you see also, you can find that patient with a unilateral exploration and focused operation also had an increased possibility of cure. But this is of course a bias and something that is not associated with the operation per se. And the reason is the following. Here is the results from sestamibi scintigraphy and ultrasound. If the patient have a positive sestamibi scintigraphy, you can see that the risk for hypercalcemia is in itself lower than if you have a patient with a negative sestamibi scintigraphy. And the same is true for ultrasound. The risk for persistent disease is lower if you have a positive ultrasound as compared to if you have a negative ultrasound. And it's quite clear that if you propose to operate a patient with a mini incision or focused operation, that patient has of course in itself a higher likelihood to have a positive localization procedure. So this must be remembered. So the impact on intraoperative PTH here was that for all patients you increased the cure rate from 92.3% to 95%, and if we analyzed only primary operation, the cure rate increased from 92.8 to 95.8. Of course, you can always think about if this is cost effective, but this was not the intent of this study to analyze. That's another question. So I want to draw your attention to a workshop we had in March in Lund, Sweden. This workshop was organized by the European Society of Endocrine Surgeons, ESES, an organization that is quite new. It was founded about 5 years ago, but it's a very nice society to be a member of. The next Congress is coming up in Vienna in May next year, and I think that if you like endocrine surgery, it's a good thing to travel there and be part of that Congress. Anyway, this workshop 2009, we had in March. Before the workshop, we had 3 different working groups. One working group for imaging, one working group for intraoperative adjuncts during surgery, and one working group for surgical strategy for sporadic primary HPT. These 3 working groups did a tremendous job. They took out and scrutinized the literature, read everything that was written, and after that they graded the evidence from the different papers. And as you know, level 1 evidence is randomized trial, level 2 evidence are prospective cohorts, and then there are comparative studies, and then number 4, that's expert opinion, that is opinion from professionals that are thought of being very particular experts in this area. To come then to what was the conclusion, because this was then published as a positional statement of the European Society of Endocrine Surgeons. It's published in Langenbeck's Archives of Surgery, and there you can find what we think are the evidence today. To begin with the preoperative imaging, sestamibi is the recommended first test, but ultrasound by an experienced investigator is an alternative, and will also identify thyroid disease. The second test is used to confirm the results of the first investigation. And if these tests are concordant, that is, that they show exactly the same thing, minimal invasive parathyroidectomy can be recommended. If only one test is positive, the patient neck can be explored on this side indicated by the test, MIP or unilateral, with the use of intraoperative PTH. If the tests are not concordant, A bilateral neck exploration can be offered, alternatively MIP or unilateral neck exploration with the use of intraoperative PTH. And if both tests are negative, I think the patient should be offered a bilateral neck exploration without further ado. All other investigations are primarily done if there are suspicions of that there is an external lesion. Regarding surgery, the initial surgical approach will depend upon preoperative localization procedures, the presence or absence of thyroid enlargement, family history, and the preference also of the surgeon. It is very important to understand that bilateral neck exploration has excellent results and is always an option for the surgical treatment of primary HPT. Selective parathyroidectomy is an option for patients with positive preoperative localization, undergoing first-time surgery, who have no family history of PHPT, no goiter for which surgical therapy is proposed, and are not on lithium therapy. MIP is considered as a safe and cost-effective procedure to treat selected patients with sporadic PHPT. Single gland excision through a limited neck exploration does not lead to an increased incidence of persistent or recurrent PHPT compared to bilateral neck exploration. And the prevalence and severity of postoperative hypocalcemia is lowered by MIP. MIP is a minimally invasive parathyroidectomy that can be performed open with a mini incision, video-assisted or endoscopic. None of these approaches appear clearly superior to others in terms of recurrent disease or postoperative complication. The use of intraoperative PTH is recommended for patients undergoing targeted parathyroidectomy on the basis of one single preoperative localization study. If preoperative localization with MIBI and ultrasound is not concordant and the surgeon wishes to perform a targeted procedure, the use of intraoperative PTH is recommended. When preoperative localization with MIBI and ultrasound, if they are concordant for a single disease, the use of intraoperative PTH is of little value. So I thank you for your attention. I hope this was not too much to digest, but this is at least where the European Society of Endocrine Surgeons stand for today. So this is the official, so to say, publication of the society. But I'm sure that there have been some months since this consensus conference, so there are new things developing. So the only thing that we know is that within 3 years, probably this consensus statement have to be revised as well. Thank you.